Hello and welcome to a recording on congenital heart disease. This is part of the Paediatrics module. So we're going to start off by talking about just as a whole some of the associations that we can have with congenital heart disease. So intrauterine risk factors for congenital heart disease include maternal illnesses, maybe if there's diabetes mellitus, maybe even if there's PKU, also drug use, alcoholism, lithium toxicity, thalidomide, phenytoin, retinoic acid toxicity, and also infections, most notably rubella, but there can be others. And generally, congenital heart disease can also be associated with fetal genetic syndromes. And we're just going to go through a list of these. These are very high yield to know, so we'll make sure we go through them. Down syndrome is associated with AV septal defects, mainly due to the endocardial cushion defects. I think most commonly atrial septal defects more commonly, but it can also be VSDs as well. Congenital rubella is associated with many cardiac defects, but the most important one to remember is the patent ductus arteriosus. But pulmonary artery stenosis septal defects can also be seen with it as well. Turner syndrome, really high yield, associated with coarctation of the aorta and the bicuspid aortic valve. Tetralogy of Fallot and Ductus Arteriosus can be seen in DiGeorge syndrome. Okay, so DiGeorge syndrome is part of the Catch-22 group of diseases, with the C being congenital heart disease, and that's usually Ductus Arteriosus and Tetralogy of Fallot. Williams syndrome, this is your chromosome 7 issue. I think it's a deletion on chromosome 7. These patients can get the pathognomic supravalvular aortic stenosis. These are also children who have like starry eyes. They often have like starry irises. They have like a very happy, jolly sort of affect, and they usually have facial dysmorphic features as well. Prenatal lithium exposure is associated with Ebstein's abnormality, which is the atrial displacement of the tricuspid valve, leading to the so-called atrialization of the left ventricle. Prenatal alcohol exposure, mostly associated with ventricle septal defects, but also PDAs, ASDs, and Tetralogy of Fallot as well. And then maternal diabetes is very, very important to remember the association with transposition of the great vessels. Also VSD as well, but more specifically transposition of the great vessels. The most important categorization that we can have about this is whether we have an acyanotic congenital heart disease or a cyanotic. The acyanotics, these are called the pink babies. These have the left to right shunt, so we're going to have oxygenated blood moving into deoxygenated areas. Or it can be due to no shunt, like an obstruction. So for example, a coarctation of the aorta, that's also acyanotic as well. And because we have no mixing of deoxygenated into oxygenated blood, we only have oxygenated into deoxygenated, we don't have any cyanosis. Our cyanotic babies, the blue babies, these have right to left shunts. So this is where deoxygenated blood is shunted into systemic circulation. This is diagnosed prenatally or immediately after birth, and it's usually requiring urgent surgical treatment or maintenance of the PDA. And this is a really important thing that they test a lot in your board exams. So the non-cyanotic heart shunts, the main ones that we have is VSD, ASD, and PDA. And the cyanotic heart shunts, you can just remember it by the T's. So Ductus Arteriosus, transposition of the great vessels, tricuspid atresia, Tetralogy of Fallot, and total anomalous pulmonary venous return. Just a quick fact, a VSD is the most common type of congenital heart disease. Ventricular septal defects most commonly occur in the membranous septum, but they can also happen in the muscular part of the septum, but it's mainly in the membranous section. And most of them resolve without intervention, but if they're really, really big, then you might have to do surgery. But we'll talk about that in more detail. We've discussed VACTERL association anyway in the neonatal unit. And just to kind of cover, it covers vertebral abnormalities, anal atresia, cardiac abnormalities, which could include ASDs, VSDs, and PDAs, tracheoesophageal fistulas, renal structural abnormalities, limb abnormalities, and hydrocephalus. And the hydrocephalus one is not usually mentioned, we just call it VACTERL, but this has been recently added. So let's discuss our acyanotic congenital heart diseases first. So these are mainly the left to right shunts. They're often asymptomatic at birth. The severity of the clinical presentation varies with the defect size, okay? i.e. if we have a huge ventricle septal defect, then we're going to have signs of heart failure. If we have a tiny little one, it's probably going to be asymptomatic. Each one has a characteristic murmur. The VSD is the most common. PDA is overall less common, but it's actually the most common in prematurity because the ductus arteriosus closes due to a mixture of reasons. It closes due to, I think, a drop in prostaglandins, and I think it also closes due to high oxygen in the systemic circulation. So if we have prematurity, we generally tend to have a hypoxia, so therefore the ductus arteriosus tends to remain closed. Uncorrected clinically significant left to right shunts can cause something called Eisenmenger syndrome. So we end up getting lots of blood going from the left side of the heart, going into the right side of the heart. That's going to cause a huge increase in pulmonary flow. Over time, we start to get pathological remodeling. This could be pulmonary artery hypertrophy of the muscles and pulmonary artery hyperplasia of the endothelium. Over time, that's going to cause pulmonary artery hypertension and even right ventricle hypertrophy. So the pressures in the right side of the heart start to go up and up and up. And eventually, that can even reverse the shunt and cause Eisenmenger syndrome. And this is often referred to as blue kids, okay? Whereas the actual cyanotic congenital heart diseases are blue babies. Whereas an acyanotic congenital heart disease that's been left for a certain amount of time that the patient then develops Eisenmenger syndrome then are referred to as blue kids rather than blue babies. Just a quick key fact, a venous hum is a benign murmur that can present in childhood. The murmur is a low-pitched vibratory murmur that is heard near the clavicle throughout the cardiac cycle. And this is unlike the murmur of hypertrophic cardiomyopathy, which is a venous hum which is loudest when sitting and disappears with the supine position or neck rotation. And I've discussed this in detail in the cardiovascular module. So let's discuss some of these acyanotic diseases. Let's discuss first the septal defects. So this is a condition in which we have a defective opening in the atria, the ASD, or the ventricle, the VSD, the ventricular septal defect. And this allows blood to flow from the atria or the ventricles from the left side to the right side. So we get a left-sided shunt. We get left-sided shunt because the pressures on the left side of the heart, so this is the left side of the heart, this is the right side of the heart, the pressures on the left side of the heart are higher, okay? Whereas the pressures on the right side of the heart are lower. So we're going to have, if we have a gap in the atria or the ventricle, we're going to have blood moving from the left to the right. And as we've said 3 times already, the VSD is the most common type of congenital heart disease. So, let's talk about the presentations of ASDs and then VSDs. So ASDs can be associated with certain conditions. Holt-Oram syndrome is a very, very rare disease. It's associated with absent radii, ASDs, and first-degree heart block. Very rare. You will very rarely get this on your board exams, but if you do, it's great if you could diagnose that and recognize that triad. Fetal alcohol syndrome, it is associated with trisomies 13, 18, 21, and it is associated slightly with Turner syndrome. The presentation, small defects are usually completely asymptomatic. Larger defects, unfortunately, can cause signs of heart failure. Okay, we can get easy fatigability because of lack of blood flow getting to certain parts of the body, failure to thrive even, and recurrent respiratory infections can ensue as well. The auscultation findings are very high yield. We get the wide and fixed split S2, so that means we have an S1 and an S2. Naturally, our S2 is split because the aortic valve closes a little bit before the pulmonary valve. And what happens here is that the S1 is normal, but the S2 is widened. But the fixed split, S2, just means that this specific splitting doesn't change with inspiration and expiration, okay? Whereas when we have some other conditions, we can have a widened S2, okay? But this causes a fixed S2, i.e. it is widened, but it doesn't change with inspiration and expiration. And do remember that's very high yield. We may get a systolic ejection murmur in the upper left sternal border. This is purely because we get increased blood flow across the pulmonary valve. And we also get a mid-diastolic rumble at the left sternal border, which is caused by an increased blood flow of the tricuspid valve. And this is essentially in an ASD, we just have more blood going from the left to the right, so it causes more turbulent blood flow across the tricuspid and the pulmonary valves, and that's what causes these murmurs. In terms of your chest x-ray findings, you may see signs of cardiomegaly, especially if there's like a concomitant heart failure as a result, and you may see increased pulmonary vascular markings. Why? Because we have so much blood going from the left to the right, this means we get more blood recycling and recirculating into the pulmonary vasculature. So that can cause congestion in pulmonary vasculature and cause increased pulmonary vascular markings. In terms of your echocardiogram, you're going to be seeing potentially right ventricle hypertrophy, right atrial enlargement, and a defect and blood flow across and you'll see the ASD essentially. Okay, so there you go. This is what it is. You can see blood is crossing from the left side of high pressure to the right side of low pressure. We can cause a flow murmur here and a flow murmur here because of this increased blood flow. Blood's going to be constantly coming into the pulmonary circulation, then coming back into the left side of the heart, then back into the right. So we get this constant circulation of more blood, which can cause right-sided hypertrophy, congestion of the pulmonary vasculature. Let's discuss now about our VSD. So VSDs can also be associated with Holter RAM, although they are slightly less common than the ASD association. Fetal alcohol syndrome as well, and then a lot of infections, toxoplasmosis, syphilis, varicella, Zika, rubella, cytomegalovirus, herpes simplex virus, so most of your torch infections. Cri du chat is also seen here. This is due to a microdeletion on chromosome 5, which they have the characteristic crying that sounds like a cat on inspiration. It is associated with the trisomies just like ASDs, and it is associated with Turner syndrome as well. Again, something that's quite important to know is that it's exactly the same as the ASD. If it's really, really small, the patients are usually asymptomatic. If it's larger, they have signs of heart failure again. So they can have easy fatigability, failure to thrive, recurrent respiratory infections, etc. And just one point about the VSD is that the murmur that we get in the VSD, which I'm going to mention in a minute, is often louder when the defect is smaller, okay? And that's because when you have small blood getting through a small space, this causes more turbulence and it makes the murmur louder. But yet the larger ones, they often don't cause as much of a murmur, but they're way more symptomatic. And I like to refer to this as all bark and no bite. It is all bark, very loud, but it's no bite. It's small and it's asymptomatic. In terms of your auscultation findings, we hear a harsh systolic murmur at the left lower sternal border, okay? And as I said already, louder for smaller defects. We see a narrow S2, okay? Maybe with an increased pulmonary valve closure sound. And we may even have a mid-diastolic apical rumble due to increased blood flow across the mitral valve, okay? Why is there increased blood flow across the mitral valve? That's because you have more blood, I'll show you. You have more blood coming into the left atrium, therefore more blood going across the mitral valve. Some of it will cross into the right side. That's going to go back into the pulmonary circulation and back again, okay? So the left side of the heart actually becomes congested. We start to get more blood going over the mitral valve. In terms of some of the chest x-ray findings, exactly the same as ASDs because we have exactly the same problem. Cardiomegaly from potential heart failure, and increased pulmonary vascular markings? Because we have increased blood going back to the pulmonary circulation. In terms of echocardiogram findings, we are more likely to see a left ventricle hypertrophy, as I've mentioned, reason why. We can still have a right ventricle hypertrophy because technically we do have more blood flow coming into the right side. And we will be able to see the VSD on an echo as well and make the diagnosis. So generally speaking, you're going to be getting your diagnosis from an echocardiogram. Just a quick key fact, this is exactly what I've been saying already, but the size of the VSD is inversely proportional to the intensity of the murmur. The smaller the VSD, the more intense the murmur, okay? All bark, no bite. And as I've said already, my ASD will cause a fixed, widely split S2. I want to talk a little bit about treatment of the defects. So most small ASDs and VSDs, they're going to close spontaneously and they don't require any treatment because they're asymptomatic. We should be doing follow-up echocardiograms essentially based on the size of the ASD and VSD and the physical examination. Antibiotic prophylaxis is generally not needed before procedures. If any of our patients have congestive heart failure developing, the best treatment involves medical management of congestive heart failure using the following: diuretics, and then positive inotropes and angiotensin converting enzyme inhibitors, urease inhibitors, okay? So very, very, very similar medications that we use for heart failure generally, okay? So if you have signs of congestive heart failure, medical therapy first. Then the question you're probably asking is, Kyle, when do we have surgical intervention? So surgical intervention is indicated in patients who fail with the medical management, are less than 1 year of age with signs of pulmonary hypertension. Okay, why is this? Well, the most feared outcome is Eisenmenger syndrome, okay, what we've mentioned before. The most feared outcome of a left to right shunt is Eisenmenger syndrome. This is very dangerous and very poor prognostic syndrome. So any child who is less than 1 year old who has signs of pulmonary hypertension, that's an indication as well. And older children with a very large defect that hasn't decreased over time. These are the kinds of patients who are indicated for surgery. Early correction will prevent complications such as arrhythmias, right ventricular dysfunction, and Eisenmenger syndrome. Okay, so early intervention, monitoring of the patient's condition is key here. So let's move now on to a patent ductus arteriosus. So patent ductus arteriosus is a failure of the ductus arteriosus to obliterate and close. Usually it becomes the ligamentum arteriosum, but in these patients it remains patent, it remains the ductus arteriosus. So what happens is we end up getting a left to right shunt, but instead of from one atria to another or one ventricle to another, it's from the aorta to the pulmonary artery, okay? And PDAs are mainly associated with prematurity, okay? It's actually the most common congenital heart disease in premature babies, and congenital rubella syndrome, which is our high yield association. This shows us just a, it looks like some kind of angiography of some form, but you can see the patent ductus arteriosus here. This is the aorta, this is the pulmonary artery, this is then going into the left pulmonary artery. You can't see the right pulmonary artery, and you can see blood. If you use Doppler, you'll be able to see blood coming through here, okay? So in terms of our history and physical examination, patients with a very large PDA may present with things like failure to thrive, recurrent lower respiratory tract infections, and congestive heart failure, exactly the same as my other shunts, the ASDs and the VSDs. Your examination reveals a very, very, very pathognomic, continuous machine murmur, heard best at the second left intercostal space, okay? Usually at the mid-clavicular area, at the sternal border, okay? Sorry, the sternal border, sorry, not mid-clavicular. You can maybe hearing a loud S2 as well. I can ask you, why do you think you would hear a loud S2? Yeah, it's because if you have blood going from the aorta through to the pulmonary artery, that's going to cause high pulmonary pressures, and that's going to increase the sound created when the pulmonary valve closes. You're going to have a wide pulse pressure. Why? The pulse pressure is the difference between your systemic blood pressure and your diastolic, okay? The systemic blood pressure here, systolic blood pressure here is not going to be affected, but during diastole, you're going to have blood that's going out into the pulmonary artery, okay? So the blood pressure is going to decrease in diastole. This is going to widen the pulse pressure. And what physical manifestations do we get with a wide pulse pressure is the so-called bounding peripheral pulses, okay? Which is essentially just characteristic of a high systole and a decreased diastole, okay? This is a very similar finding to what you would see in aortic regurgitation as well. Uncorrected patent ductus arteriosus will eventually lead to a cyanosis, okay? This is exactly the same mechanism as the Eisenmenger syndrome that we discussed in VSDs and ASDs. However, if you have a look at the anatomy of the aorta, okay, and then the anatomy of the pulmonary artery, the ductus arteriosus is here, okay? So most of the branches that are going to be going to the head, to the arms, they've already branched off, okay? But when we get Eisenmenger, which is essentially a reverse of the shunt, we're going to start to get deoxygenated blood going through the ductus arteriosus and then going down distally through the aorta. So this is going to cause cyanosis, but it's only going to cause cyanosis of the lower extremities, because these upper extremities have already had their blood supply before the ductus arteriosus. And this is something called differential, differential cyanosis, i.e. an Eisenmenger syndrome causing cyanosis of the lower extremities, but not of the upper extremities. Normal fingers, blue toes, okay? So, how do we diagnose a PDA? Best initial test for almost all of my congenital heart diseases, echocardiogram. That's going to demonstrate the defect. You can use a Doppler as well to see the flow of blood going from the aorta to the pulmonary artery. Large PDAs will also show left atrial and left ventricular enlargement. And the question you've got to ask is, well, why would it cause that? Well, again, just like ASDs and VSDs, we're going to get more blood going back into the pulmonary circulation. Therefore, we're going to get more blood coming back into the left side of the heart, okay? So eventually the left atria and ventricle will become enlarged. I've already said you can do a Doppler color flow demonstrating the blood shunting. You can also do an ECG, which may start to show some of these heart structural changes, left ventricular hypertrophy, and maybe a chest X-ray, which will reveal cardiomegaly. So, regarding your treatment, the best initial treatment, and this is really high yield, is indomethacin, okay? And indomethacin, I always like to call it indoor methacin, because you close the door. Indoor methacin, close the door, indomethacin. And this is an NSAID, and essentially it's going to, give me a minute, I want to make sure, yes, it's closing the ductus arteriosus. So it's an NSAID, unless the PDA is needed for survival, yes. So we give indomethacin to close the PDA, which is great. However, if the patient has a concomitant cyanotic heart disease, i.e. transposition of the great arteries, Tetralogy of Fallot, hyperplastic left heart syndrome, etc., we don't give indomethacin because we rely on the PDA as a shunt of shunting some of that oxygenated blood back into the, it's essentially to reverse the shunt, okay? So if a patient has a concomitant cyanotic heart disease, you do not give indomethacin. In fact, you would give a prostaglandin to keep the PDA open, okay? Because that's going to help reshunt some of that deoxygenated blood back out of the systemic circulation. So for PDAs without any concomitant cyanotic heart disease, we give indomethacin. If that fails, or if the infant is more than 2 weeks of age, we can then have an indication to do surgical closure instead. Okay, so indomethacin, if it doesn't work, surgical closure. If a concomitant cyanotic heart disease cannot do indomethacin, we want to keep the PDA open. And then just a little mnemonic. I don't really understand this mnemonic, so I'm going to leave it. If you like it, you can read it, but I'm not going to read that. So I'm just going to read a few key facts. Coarction of the aorta and bicuspid aortic valve are associated with Turner's syndrome. If you've done your step 1, this is easy peasy. In infants presenting in shock within the first few weeks of life, it could be due to a few different things. Sepsis potentially, maybe even inborn errors of metabolism, ductal dependent congenital heart diseases, okay, and usually left-sided lesions, and maybe even congenital adrenal hyperplasia as well. So let's discuss the coarction of the aorta now. And this, in theory, is a very easy disease, but it's actually more complicated than one thinks. So coarction of the aorta is an aortic narrowing, usually near the insertion of the ductus arteriosus. We call it a juxtaductal coarction. Okay. We can have one of two variations of this. We can have it after the ductus arteriosus, but we can also have it before the ductus arteriosus. Okay. I think for sake of simplicity, we are only going to talk about the type that is after the ductus arteriosus. Okay, we're only going to talk about that type. But I just want to kind of keep in your mind that there are two different types and the presentation is completely different. So, if we have a narrowing of the aorta near the ductus arteriosus but just after, we are going to have increased proximal flow, proximal to the PDA, and we're going to have a decreased blood flow distal to the coarction, So proximal to the coarction, low blood flow. After the coarction, before the coarction, increased blood flow. After the coarction, decreased blood flow. We've already discussed 100 times, it's associated with Turner syndrome, bicuspid aortic valves, and it's found more than 2 out of 3 cases, whatever. And a very high yield association is that it's associated with intracranial aneurysms, specifically berry aneurysms, okay? So these patients are at risk of getting strokes when they're older. It's more common in men, and complications can include heart failure, aortic rupture because of the increased pressures proximal to the coarction, endocarditis, and cerebral hemorrhage due to berry aneurysm rupture. So I just want to discuss this diagram just a little bit. As I said before, we can have the coarction before the PDA or after the PDA. Just for simplicity, we'll talk about after the PDA. We're going to have our increased blood flow here. The pressures are going to be very, very high, okay? The pressures after it are going to be really, really low. So if you take the blood pressures in the arms, the blood pressure is probably going to be high. If you take the blood pressures in the leg, it's probably going to be low, okay? And that's one of our diagnostic tests that we can do. One thing I also want to mention is that we do get a shunting of blood due to this high pressure. So this high pressure can start to vascularize the intercostal arteries. This is like a bed of arteries which are not so used in normal patients. But when we have a high pressure prior to the coarction, we can start to sort of congest these intercostal arteries, okay? And these form networks leading back to the descending aorta to essentially bypass this problem. And this is something that happens in utero, okay? Very important. So let's talk about our physical examination in history and how we can spot this in a case. If not detected in newborn screening, then it will present in childhood with asymptomatic hypertension, usually isolated to the upper extremities. And a classic finding, physical examination finding, is a systolic hypertension in the arms, but a low blood pressure or weak or delayed pulse in the lower extremities. And this is called the brachiofemoral delay. So if you have a case where they say the systolic blood pressure, the blood pressure in the arms was, 140 over 90, but yet in the legs it was 110 over 60, then this is a huge brachiofemoral difference, and this points towards a coarction of the aorta. The difference in blood pressure between the left and right arm can indicate a point of coarction as well. So if the coarction is, let me just show you, if the coarction is before the brachiocephalic arteries, i.e. if the coarction was here, we would have a blood pressure discrepancy between the arms. But obviously in this specific picture, the point of coarction is after the brachiocephalic arteries, i.e. your subclavians and your internal carotid and your common carotids. Therefore, the blood pressure will be same in both arms. So really, the signs and symptoms do depend on the presentation clinically. A systolic ejection murmur can be heard, but also a continuous murmur may be heard in the interscapular region. Why? This continuous murmur in the interscapular region is due to the intercostal arteries. These congested intercostal arteries will be creating this interscapular murmur. Okay? A lot of people have told me in the past that it's due to the coarction itself, but this is not true. The one that you hear in between the scapula is due to this intercostal artery vascularization. You may see signs of low blood flow to the lower extremities, so maybe you see lower extremity claudication due to a relative ischemia in the legs. Maybe you even see signs of syncope and epistaxis. Epistaxis because the blood pressure in the head and the neck region will be elevated, and headaches for the same reason as well. In infancy, critical coarction requires PDA for survival. Okay, such infants may present with first few days of life with poor feeding, lethargy, tachypnea, and eventual shock-like state when the PDA closes. During the newborn screening for coarction aorta, differential cyanosis may be seen with lower O2 saturation in the lower extremities, postductal areas, as compared to the right arm, preductal area. So this statement here, you may already know this, but you may be looking at this and thinking, what on earth is this saying? And this is exactly what I was mentioning before. You remember when I said some patients have their coarction before the ductus arteriosus? This is what happens when this happens, okay? And I'm going to very briefly describe it. It is quite complicated, but I'll briefly describe it. So, if you have your aorta here, okay, you have your pulmonary artery, okay, and you have your PDA. Let's say your coarction of the aorta is here. Let's say this is in a fetus, okay, this is in utero. What is the problem here? The problem is, in utero, I'm going to be having lots of blood flow coming from the pulmonary artery through the ductus arteriosus and then into the aorta. This is fine in utero because we don't have much blood flow coming up here. Remember, in utero, the pulmonary artery system is much higher pressure than the aortic. So it's okay. The body is going to be getting lots of blood because we have this channel here. But when the baby is born, when the fetus is born, the PDA closes. What happens now? I, unfortunately, have to have my blood going like this. But because I have a coarcted aorta, the blood is so heavily obstructed. So this patient ends up getting these signs as mentioned here. Shock-like, tachypnea, lethargy, poor feeding, all these signs and symptoms because of this problem. Whereas in the case that we discussed up here, this was a case where we had the coarction of the aorta after the PDA. Okay, so let me just draw it out again. So in this case that we were discussing, I said for simplicity, let's just keep it about this kind of case. We have the coarction here. So what happens? We have blood flow coming from the pulmonary artery, but it can't get past the coarction. So what happens? We start to revascularize or vascularize and use this collateral network of intercostal arteries. So we essentially bypass the obstruction. So then at birth, when the PDA closes, what happens? My blood comes up here, but it's not a problem because I have a bypass because of this vascularization, this using of this intercostal arteries. Okay, so that's why whether your occlusion, your coarction is before or after the PDA completely changes the clinical presentation. Okay, in most cases of coarcted aorta, you're talking about the coarction after, and that's what all of these signs and symptoms that we mentioned relate to. But if the coarction of the aorta is before, it's a completely different presentation. It presents like this instead. Okay, so please keep that in mind. And these specific cases where the PDA, where the coarction is before the PDA, we need to keep the PDA open so that the patient can still get adequate blood flow to the rest of the body. Good. So hopefully that's cleared that up. I hope that hasn't overcomplicated it. So let's just talk about diagnosis now. The best initial test, as I said, like all congenital heart diseases, echocardiogram with a Doppler color flow. If presents late in childhood or young adulthood and it's untreated, a chest x-ray can develop and show findings such as cardiomegaly, pulmonary congestion, which is seen in infants because of the vascularization of those intercostal arteries, and the rib notching as well. These are all relating to that vascularization of the intercostal arteries. We can also see a classical 3 sign as well due to the coarction, which is created by essentially the coarction creating this appearance like this. So if the coarcted aorta looks like this, for example, it can create a B appearance on the X-ray. And here's a really good kind of example of that. So here you see the rib notching here and here. This is because of the post-PDA coarction of the aorta that's led to that congestion in the pulmonary arteries, and now you see this so-called rib notching. And here you can see the B. Okay, you can see that very nice B sign. Good, and I'm not going to go into too much more detail than that. And of course, in older children, we might start to see signs of left ventricle hypertrophy on the ECG, as seen by Sokolov's criteria. In terms of treatment, the best initial treatment if severe coarction in infancy, i.e. my pre-ductal coarction, we're going to be giving prostaglandin. Why? That's going to keep my ductus arteriosus patent, and it's going to allow blood to still get past and bypass the coarction. Okay? And that's only just to wait until you can do surgical repair. Surgical repair in infants and toddlers or balloon angioplasty in older children can be done. This is for the cases of post-ductus arteriosus coarction. And of course, you need to be doing monitoring. Monitor for hypertension, monitor for restenosis. Also check out for aneurysm development, especially in the brain, and always keep an eye out for aortic dissection. So that's kind of completed the non-cyanotic heart diseases. I'm now going to go into the cyanotic heart diseases. These are going to be babies that are born and they present with a central cyanosis. Okay, so you look in the baby's mouth, you look under their tongue, and it's blue. Or around the mouth, you'll see blue tinge of the lips. So the cyanotic heart defects, the 5 T's that have right to left shunts, truncus arteriosus. So that is essentially where we have one giant opening coming from the left and right ventricles. So it's kind of a mix of both the pulmonary artery and the aorta. Transposition of the great arteries, which is where the two arteries are switched over. Tricuspid atresia, which is 3 because it's tricuspid, so that's essentially where on the right side of the heart, there's no movement of blood from the right atria to the right ventricle, so it has to almost depend on a bypass, ASD and VSD respectively. We'll discuss this. Tetralogy of Fallot, okay, obviously that's 4 signs, so 4. And then total anomalous pulmonary venous return, and they just said 5 words. But I think, again, if you've done step 1, you'll know all of these anyway. Just a quick key fact, cyanotic congenital heart disease does not respond to 100% oxygen challenge, okay, minimal effect, whereas most lung pathologies do respond. So when you have your cases of a neonate who's got cyanosis, in a lot of questions they love to put like the 100% oxygen challenge, and they're going to then tell you what was the PaO2 levels before and after this challenge. If they markedly improve, it's probably more likely a lung pathology. If there's no improvement, it's probably a cyanotic congenital heart disease. So let's have a go at going through these. So we're going to start off by discussing transposition of the great vessels. Really easy to understand. It's among the more common cyanotic congenital heart diseases in the newborn. It's essentially where the aorta arises from the right ventricle, where normally it arises from the left, and the pulmonary trunk arises from the left ventricle, whereas usually it should arise from the right. So what happens is that this is completely incompatible with life as it stands, because if I have blood coming from the left atrium, left ventricle, into the pulmonary artery, that's going to go into the lungs, it's going to come back, and it's going to come through the pulmonary veins and back again. If I have the aorta coming from the right ventricle, that's going to go to the aorta, it's going to go to the capillary beds, back through the IVC and superior vena cava, back to the right atrium, and again. So this is closed circuits. There's no mixture of the pulmonary and systemic circulation. So essentially, in order for the baby to survive, we need shunts. We need ASDs, VSDs, PDAs. We need ways for us to create connections between these two circulations. So we have separation of the pulmonary and systemic circulation. Life is incompatible unless a shunt is present to allow the mixing of the blood, VSDs, PDAs, or patent foramen ovale. A PDA alone is usually not sufficient to allow adequate mixing of the blood. Okay, so a PDA is very, very small, so we usually need more. We usually need an ASD or a VSD. And risk factors, we have discussed them already. The big one is pre-existing diabetes. Okay, rarely DeGeorge syndrome. Okay, you're going to have many other signs and symptoms with DeGeorge syndrome, like facial abnormalities, cleft lips, cleft palates, thymic aplasia. But the pre-existing diabetes is the one that they're going to want to test you on. So in terms of your history and physical exam, transposition of the great arteries typically presents within the first few hours of birth. Okay, so it's going to be occurring very early on, and it is not affected by exertion or supplemental oxygen use, as we mentioned. We can get reverse differential cyanosis, so higher postductal saturations than preductal saturations. May only be seen if the left ventricle outflow tract obstruction is seen, maybe an aortic stenosis or a coarctation is present. But the main things you want to be looking at on physical examination, you're going to be seeing extreme cyanosis, hypoxemia, and tachypnea. Okay, some other signs to look out for: signs of heart failure, a single loud S2, so no splitting, and a systolic murmur, and that only if there's a coexisting VSD. So, how do we diagnose this? What did I say before? The single best diagnostic test that I do for all of my congenital heart diseases is an echocardiogram, okay? And that's going to be showing everything you really want to see. It's going to be showing an aorta coming from the right ventricle and a pulmonary artery coming from the left ventricle. You can do an X-ray, it's not necessarily required, but you do see the very famous egg on a string appearance. I'm not sure if they have a picture of that, they don't. But essentially it's where the heart sort of looks like an egg shaped. Okay, so it looks like an egg that's been like held up by a string. Okay. So in terms of your treatment, best initial treatment for almost all of my cyanotic diseases is intravenous PGE. Why? Because I want to keep my ductus arteriosus open. Why? Because this is going to allow a shunt and it's going to allow mixing of my two circulations, which is what I want. To allow for some time, this is also essentially we give the PGE. This is just going to give us some time to essentially assess the surgical viability and also to improve surgical outcomes. We can do a balloon atrial septostomy, is performed to create a shunt, especially when you haven't got a reliant PDA shunt and prostaglandin infusion. So essentially, if you haven't got a great PDA, you can do an atrial septostomy. But again, it's not a curative treatment. The most definitive treatment, on the other hand, is a surgical correction. And this surgical correction is very, very complicated surgical procedure, but it involves essentially an arterial switch operation, which you can look at in your own time, but your board exams are never going to test you on these details. Okay, we're now going to move on to Tetralogy of Fallot. Tetralogy of Fallot is your 4 signs, and it's going to consist of a right ventricle outflow obstruction. Okay, this is usually caused by a thickening of the infundibulum, which is just the part of the ventricle, the right ventricle, just before the pulmonary artery, and this tends to cause like a subpulmonic valve stenosis, overriding aorta, right ventricle hypertrophy, and a VSD. It is among, again, like transposition, it's one of the more common cyanotic congenital heart diseases. You usually see early cyanosis because of this right to left shunting across the VSD, but you're probably thinking, Kyle, you said before if I have a VSD, I'm going to have left to right shunting. I'm not going to have any cyanosis. And that's a good point, but the problem is due to this subpulmonic outflow obstruction. This creates a really high pressure here, and that forces blood to go into the left side. So even though we do have higher pressures here and lower pressures here, because of this outflow obstruction, we get blood that occasionally moves into the left side, and that's what causes cyanosis. So most Tetralogy of Fallot patients don't get cyanosis all the time, like all the other cyanotic diseases do. They get cyanosis intermittently when we have times that increase this pressure and causes more of this shunt. As right-sided pressures decrease in the weeks after birth, the shunt direction reverses and cyanosis resolves. This is just because as a neonate gets older, the pulmonary pressure starts to go down, and that can help the cyanosis. If the degree of pulmonary stenosis is severe, the right-sided pressures remain high and the cyanosis may persist. And we've already discussed some risk factors before, but trisomy 21 is a big one, and DeGeorge syndrome is a big one as well. So just a little thing about DeGeorge syndrome on a side note, because we've been discussing DeGeorge syndrome in a lot of detail, is its signs and symptoms. So DeGeorge syndrome is part of a spectrum of diseases that are referred to as the catch-22. The catch-22 is known for cardiac abnormalities, abnormal facies. This can be seen as retrognathia, micrognathia, a long face, short philtrum, low set ears. The T is for thymic aplasia, the C is for cleft palates, the H is for hypocalcemia, and this is because of hypoparathyroidism, because the parathyroids are agenic, and the 22q11 deletion, 22q11 deletion, which is the specific area on the chromosome where we see the microdeletion. And DeGeorge syndrome is the most severe of this spectrum. Okay. In terms of your history and physical examination, Tetralogy of Fallot presents in infancy or early adulthood with dyspnea and fatigability, and you're going to be seeing cyanosis. Okay, but you don't just see cyanosis continuously. You see essentially cyanosis in spells, but we're going to discuss this in more detail. So cyanosis is frequently absent at birth, but develops over the first 2 years of life. The degree of cyanosis is reflected based on the outflow obstruction. So basically, how obstructed this specific infundibular area is will determine how much cyanosis you have, because this determines how much of a shunt you're going to get from the right side of the heart to the left side. Okay? So it all depends on that right ventricle outflow obstruction. As I said, infants are usually asymptomatic until 4 to 6 months of age, and this is when things like congestive heart failure may develop, and they may have signs of diaphoresis with feeding or tachypnea. The children have these things called TET spells, okay? And a TET spell is whenever we get a sudden shift of blood, essentially from the right to the left. So things like feeding can cause it, things like crying can cause it, and that's because all of these things increase pulmonary pressures, which increase pulmonary artery pressures, which then increase the shunting from the right to the left. Okay, so we have spells of cyanosis. Children usually squat to help relieve this. The squatting essentially increases the systemic vascular resistance, thus increasing the blood flow back into the pulmonary vasculature. So if a child squats, that's going to increase the pressure in this system. Therefore, I increase the pressures in the left side of the heart. So that's going to sort of stop this shift, okay? It's going to stop this right to left shift, and it's going to push more blood back into the pulmonary circulation. Hypoxemia may lead to failure to thrive and maybe even cognitive and developmental delays. Physical examination can reveal a systolic ejection murmur at the left upper sternal border, and this is purely due to the pulmonic stenosis. We may also have a harsh hollow systolic murmur at the left lower sternal border, and this is typical for my VSD. So just a quick key fact, both the transposition of the great arteries and Tetralogy of Fallot are initially treated with our PGE1 infusion. However, this is just to delay surgery so that I can let the baby grow a little bit, evaluate the best surgical intervention, but always my definitive treatment is surgical correction. So now, regarding our diagnosis, the best initial test, what did I say? Always echocardiogram. You can also do catheterization as well. You can do a chest x-ray, and that shows the characteristic boot-shaped heart with decreased pulmonary vascular markings because I have less blood going to the pulmonary arteries, okay, because of the pulmonic valve stenosis. Remember that an isolated VSD without right ventricular outflow tract obstruction may result in increased pulmonary vascular markings. We mentioned in patients with VSDs and even ASDs, they have increased pulmonary vascular markings. But because we have in Tetralogy of Fallot, we have that right ventricle outflow tract obstruction, we're going to get less blood into the pulmonary vasculature, and therefore we have decreased vascular markings. So that should make sense. And an ECG will most likely show right ventricle hypertrophy, which is one of the hallmarks, and the right ventricle hypertrophy can cause a right axis deviation. And how do you tell if somebody has a right axis deviation? That could be your homework, but you usually look at leads 1, 2, and 3, and you look at the QRS, essentially deflection, and if you see it going like this, i.e. negative deflection, positive deflection, that's a sign of right ventricle hypertrophy. So, to finish this, I want to talk a little bit about treatment. The best initial treatment, if there is severe outflow obstruction or atresia, is prostaglandin. Why? I want to keep my PDA open to help reverse the shunt. This should be done in conjugation with a surgical consultation as well. A very high yield thing is to know how to treat the TET spells, okay? So those children that end up having spells of cyanosis when the pulmonary vascular resistance gets higher. We usually treat this with supplemental oxygen, okay? And also placing a patient in a knee chest position. This is going to increase my systemic vascular resistance and it's going to help reverse the shunt. If that does not resolve the symptoms and we need further treatment, we can give IV fluids, opioid analgesias, because they're very painful, beta blockers, and alpha agonists. The alpha agonists are going to increase my systemic vascular resistance and help reverse the shunt. Temporary palliation can be achieved through creation of an artificial shunt. This can be done via our balloon atrial septotomy, which we did also in transposition of the great vessels. And this is usually done if we really require a shunt, if the patient's got very severe symptoms, just before we do a surgical management. Okay, and generally the surgical management that they discuss is the modified Blalock-Thomas-Torzig shunt. Is often the first step. But for steps and for most of your university exams, you don't need to know complex disease management. So if you want more information on the congenital heart diseases, we have missed, first aid hasn't discussed Ductus Arteriosus, it hasn't discussed tricuspid atresia, and it hasn't discussed total anomalous pulmonary vein return. So if you want to look at those in more detail, please feel free to kind of check it out, but they're really not that common, and they're not really tested much in the USMLE. So I hope that helped, and on to the next.